The shoulder.
We're going to be covering the shoulder today, and it is part of the upper quadrant of the body. Actually, we need to consider the sternoclavicular joint as well as the acromioclavicular. A lot of attention is given to the glenohumeral, and we have the pseudo joint called the scapulothoracic. So we'll start with the anatomy, and it's always something you can rely on because it never changes. Taking a posterior view of the right shoulder, we'll just zoom in on the shallow glenoid of the scapula and that nice, almost spherically shaped humeral head. That's sort of the deepest part of the glenohumeral joint. As I mentioned, the glenoid is part of the scapula. And I like to be as anatomically accurate as possible. Here we go. And from the root of the medial part of the scapula, we have the scapular spine, which terminates as the acromion. And the little notch of the nerve. And whenever you have a neck, a humeral head rather, you have to have a neck. And these are the bumps of the tuberosities. This is just the bone. We need to add things to it. So, right here we have an extension beyond the margin of the glenoid of fibrocartilage. That's called the glenoid labrum. If we were to look at this from a lateral view, it's ovoid in shape, and this fibrocartilage goes around the margin of the glenoid, extends beyond it. It has a central clearing. If we were to slice it, take a look at it, you'll see that it forms an edge in a way that it actually helps this humeral head stay seated in the glenoid. Defects can occur here, especially by way of a dislocation, where the humeral head has to violate or compress part of the labrum in becoming dislocated. So you end up with sort of a crush or even a tear or a fracture of that part of the labrum, which creates a path of least resistance for future dislocation and joint instability. Now, at times you'll get a patient who says, yeah, my shoulder dislocates all the time. And you're questioning that. Or perhaps they had something happen in their history that suggests they had an anterior dislocation. So we can do a test called the apprehension sign. So we're going to check for a history of dislocation. That's the purpose of the test, and it's look for the apprehension sign as we put them in a position that could dislocate if they've had a history of that. So I'll demonstrate that to you. Good. So I'm going to cradle the upper extremity, bring her into 90 degrees of abduction, and externally rotate. We are not trying to create pain or dislocation. We want to see if it creates apprehension for the patient. I take my thenar eminence and put it right behind the humeral head and put a little spring
show what apprehension would look like.
and that's the apprehension test. It's not a highly sensitive test, but it can help suggest that indeed this patient had had a true dislocation. Now, in addition, we have the labrum here, and we have another structure that comes in, and I want to bring it in now, and it attaches right to the superior labrum. Viewing my drawing here, it would be on the front of the humerus, And it comes through up the bicep groove between the two tuberosities, and it connects to this superior labrum. If I take the first letters of what I just said, the superior labrum, but superior labral, we're going to add a couple of other words. Anterior, posterior suggests the plane of this type of a tear. If you take the first letter of each of these words, you're going to get slap. And that is the description for a tear that occurs with the attachment of the tendon of the long head of the bicep to the superior labrum. If I were to pull it into the room, it would create a tear like so, and it extends in the anterior posterior plane. That's called a slap defect. There is the test for this. It's called the O'Brien test. And it has a control and the actual test. Both are done with the shoulder joint flexed 90 degrees and adducted 10 degrees. The control, we're going to have the thumb up. If there's no pain when you do the control, then you can go on to the test, which is to internally rotate or have the thumb down. What happens when the thumb's up? The bicep tendon is supported. When you internally rotate, you no longer have that support, and a lot of the load falls to that tendon. If the patient is weak or has pain with the test, then it suggests that there's been an injury, possibly a slap tear. Please. So for this, I'm going to actually have you stand up a second. Okay. I forgot to orient this the way I want. It's up there that way. Okay. Now, I'm going to demonstrate the control, 90 degrees, 10 degrees. Okay, resist my pushing down on your arm. There. No pain? No pain. Perfect. Then we're going to rotate and repeat. So with this test portion, she would either have pain and or weakness to suggest that there's been an injury to the slap, or a slap tear, sorry. Finally, with the deep structures of the shoulder, the next stabilizing structure is actually the capsule. The joint capsule, it encapsulates it. It attaches all around the perimeter of the labrum and the humeral neck, and the fibers go across, but they're extremely thick at the top, and they thin out, and then they get very thick down here as it forms the axillary pouch. These two parts of the capsule are called ligaments: superior glenohumeral ligament and inferior glenohumeral ligament. They function to stabilize the joint, not merely to encapsulate. So we can test the capsular integrity by doing a passive anterior-posterior glide. So I'm going to use one hand to stabilize the scapula, because that's where the glenoid is. My heel of my hand is right at the scapular spine, and my fingers curl over. So it just keeps that fixed. The other hand goes right where the humeral head is, as high as you can go. I suggest not using digging fingers but pads. And we're going to glide the joint in an AP direction, a little bit inclined toward medially as you go forward. I like to have the arm resting there. There we go. Now hers is stable, but a lot of times when you apply posteriorly directed force, it'll kind of clunk out. And that is positive for having laxity in the capsule. Okay? So I'm going to put that up here, and that will kind of conclude our discussion of the deep structures.
And what causes the laxity?
Laxity can be caused, okay, hang on. Just make it simple, capsular tightness. You do it passively, that means you do it to them. They don't have to do anything. With anterior, posterior, glide. Laxity is caused often by repetitive motion. I see it a lot in swimmers. Butterfly strokes, so you're continually subjecting this capsule to stretch to the point where the elasticity has been lost and you don't get that added stability. But what is true in these cases is if they maintain the strength of the rotator muscle group, rotator cuff, they can compensate. They can provide that stability from that. The second scenario are those who have connective tissue laxity. So the Ehlers-Danlos spectrum. And we find individuals who are just loosey-goosey all over. And when they go to sleep at night and their muscles relax, it falls to the connective tissue to maintain the joints, and then clunk, they go out of joint, they get their pain at that time. So, that's an answer to that. Okay, shall we just
I'll pause here.